Alrighty, chapter 13, ear, nose, throat, and mouth. Some of the anatomy of these structures is a little bit ridiculous. And your text goes into like quite the detail. We won't be, that hard and fast about all the nitty gritties, but in general, it's important to know generally what's going on. Okay. So for your ear, the pinna or the auricle is the big like outer ear part that you think about, like right here. Then the external auditory canal, that's the part inside that leads up to the tympanic membrane. And the external ear and the middle ear are separated by that tympanic membrane. And the middle ear consists of, the ossicles, the malleus, incus, and stapes, and that's what helps move in order to help us understand sound. But then the inner ear is the vestibule, semicircular canals, and the cochlea, where sound is actually transmitted into your brain. Okay, this is what that looks like. Let me figure out which one's the pen again. So right here, oh, hopefully you can see that. Let me just do this one just to be sure. Okay. So this is the external auditory canal. This is that membrane right here. And then behind it is all the extra fun structures of hearing. Okay, and then the auditory nerve is over here. Oh, I can just use my finger, that's better. Okay, and then eustachian tubes, which is this down here, will be really important moving forward when we talk about some of the illnesses and such. And so right now, look, this is the anatomy of an adult head, and I know that because the eustachian tubes are relatively up and down. If it was a younger person, it would be more flat like that. Okay. Okay, and so then this is how, hearing occurs. So at first on the left, they're showing the difference between bone conduction and air conduction. Okay, and so when the bone conduction occurs, it kind of bypasses all of this and can go straight in to those inner ear structures. And then the air conduction, meanwhile, comes in from the outside, and just different wavelengths. Oh goodness, wavelengths. Okay, are transmitted via bone conduction versus air conduction. And like one way we test this is you take your tuning fork, like you slap your hand, you put it on somebody's head, like right here, right behind their ear, and you tell them to tell you when it stops, when they can stop hearing it. And then if you move it forward, they can actually hear it again. Okay, because the air conduction lasts longer. Okay, so nose and nasopharynx. The bone in the proximal third of the nose, like up here, is actually bone versus everything down here is cartilage. Your internal nose is divided into two anterior cavities or vestibules by the septum. So, the thing in the middle. And then the three turbinate bones form the lateral walls of the nose. Remember, lateral is outside. And paranasal sinuses are air-filled spaces within the cranium. So this is kind of what that looks like. So on the right, you'll see the superior turbinate, middle turbinate, inferior turbinate. Just know that, there's three of them and that they occur kind of on the outside. And then it's separated by the septum, and then you look to the other side. And then this on the left is just a different view. Okay. And so this is the opening to that auditory eustachian tube that we saw a couple slides ago. Okay. And then the thing I want to highlight in here is, do you see how just like all of this is connected? Okay, so because this is the entrance to your nose there, and then it can go back and down here. So you can have throat pain right there and that be 100% be starting from up here in your nose. Okay. So just keep in mind, like, all of this is connected. And that's why, you know, oftentimes with viral illnesses, people don't just have a runny nose, they have a sore throat or they have a cough or something, because it all just kind of goes together. Okay, and then this is a look into the mouth. Hard palate is this top part up here, and then further back down there is considered your soft palate. And if you were to actually like run your finger along somebody's mouth, you could tell the difference. Okay. So when you go to the doctor's office or the dentist or whatever, and they make you say ah, it's not just for grins and giggles. It actually makes the uvula come up and your tongue go down. So that's why we do it, because otherwise often all we can see is your tongue. And we got to get that tongue out of the way so that we can see the uvula, which is this dangly thing. And then the tonsillar pillars back here. Okay. Because those can get really red and inflamed. And they get big, and sometimes they're called like kissing tonsils, is a sign of, you know, really severe like pharyngitis, because those tonsils are almost touching, and that could actually even lead to like an airway problem. Okay, and then this is more anatomy of like the tongue and such. I mean, I don't really ever have an indication for that. Obviously, you shouldn't see lumps, like masses, weird colored things. It should all be that like pinkish coloration. And if you see anything that you're concerned about, as we'll talk later, you need to refer them to. These are like the salivary glands. Okay, so parotid gland, I think of mumps, because that can get pretty, like, you know, swollen. Otherwise, don't really worry about it. Teeth. There's a reason I'm not a dentist. Teeth are weird. Um, I guess I lied. I have two things in healthcare. It's teeth and eyeballs. Anyways, this is what's normal. Okay. This is the anatomy of the tooth. Okay. And so you can see the nerves, like, actually, like, they're running kind of down the bottom, but they go up pretty high. And so with like poor dental care and such, it doesn't take a lot to get down into nerve pain, and nerve tooth pain is pretty bad. And so when they say somebody's saying like they have a root canal done, they're essentially hollowing out this whole canal right there. Oh, maybe I should do a different color. See this whole thing right there, and filling it up with stuff so that their nerve is no longer irritated. So evaluation of ear, nose, mouth, and throat, the auricles and mastoid areas. So here, I don't know if you can see, here and then like here, okay, are palpated for point tenderness, swelling, and non-visible nodules. There are lymph nodes that are right behind the ears as well. The otoscope with a disposable speculum is used to inspect the ear canal. I really don't understand when there would be a case that you guys would be doing this, but I don't know. I mean, I feel like if you think you need to look inside their ear, they should probably be seeing somebody anyways, because if you're looking inside, you're looking for, you know, either something stuck in there, which happens a lot, or like infection or something, and meanwhile you guys don't have the ability to treat it. So I don't know. Anyways, that's how you do it. This is what the tympanic membrane is supposed to look like. Nobody's is that perfect, because oftentimes the angles of their external ear canals make it really hard to see the whole tympanic membrane. But in a normal person without, you know, infection or anything else going on, it's this pearly gray type structure, and you can see that cone of light that's reflecting from your otoscope. And you can see these, we just call them, like when I chart, I just call them landmarks visible. I don't say, you know, oh, the incus and the malleolar striae or whatever it's called. Like it's just landmarks are visible, because if they weren't, that would mean that the tympanic membrane is bulging out. Okay, so like these parts here, there would be so much pressure behind them that that part would bulge out and make it all look flat so that I couldn't see what was going on. So that would tell me that there's something behind it increasing all that pressure. Hearing loss evaluation, honestly, a lot of times you can tell just with speaking. If you just walk into the room and people look at you with a blank stare, or oftentimes they'll be like, you know, I'm sorry, I can't hear you, those kinds of things. You can do the Weber and Rhine tests as well. Those are with your tuning fork. Oftentimes I don't feel like I really need to do this to know that somebody has some hearing impairment. Most of the time it's just pretty obvious with conversation. And then if truly somebody complains, you know, I just can't hear correctly, I'll send them to like an ear, nose, and throat doctor for like official testing, because I don't necessarily know, like the Weber and Rhine are great tests and such, but in order to get anything to maybe improve their hearing, they would have to go next step further anyways. Nose and nasopharynx. You want to know, just like we've talked about with your old carts, what's the onset? What's the duration? When did it start? Is it getting worse? Is it getting better? Is there any type of obstruction in the nasal cavity? Is it bilateral, unilateral, or is it all the time? So do people just feel plugged and congested all the time? Are they still able to, you know, breathe in through their nose and out through their nose? If there's drainage, what color is it? Is it thick? And then you would palpate the facial bones and sinuses to determine areas of tenderness, swelling, or deformity. And then, so nasal conditions with drainage. So this is part of why we care what color it is. Here's a little bit of a disclaimer though. Everybody's always like, oh, well, yellow or green snot's coming out of my nose, so that means I need an antibiotic, which is not true, okay? And so yellow or green discharge is likely like a sign of like a sinus or upper respiratory infection, but it could still 100% be viral, okay? I'm not sure if you guys have talked about, you know, with interventions like the number needed to treat. And so that's essentially like, how many people do I need to treat to avoid one like serious case of something bad going on or something? And anything above 10, like I need to treat 10 people to prevent one case is really not that great of an intervention. And antibiotics for sinus infections is like a number needed to treat of like 12 or 13. Okay, so it's really not a good intervention, because honestly what happens is, you know, people come in at about day 4 or 5, they're like, oh God, I feel so awful, I have so much pressure, I'm so congested, and then they start their antibiotics and then they start to get better, but really they're not getting better because of the antibiotics, they're getting better because of the natural course of the viral illness. Okay. Otherwise, the watery discharge can also be, you know, from a viral infection. It doesn't have to be that cut and dry. Like yellow and green doesn't automatically equal like bacterial. Okay. So a speculum exam, once again, like I don't really know why all you guys would be doing this, other than if you thought there was something stuck up in there. Oh, and I have this conversation with people, with younger people at times. Never put anything anywhere you wouldn't want to explain to the paramedics. Okay? And you can say that for any orifice. Like, don't shove anything up in there if you don't want to have to explain it. Okay? And so I've had people come in with Legos in their nose, like not just kids, but like older people, or grapes in their nose, those kinds of things that got stuck. So yeah, just a good, actually, you know, never, like, just don't do anything you ever wouldn't want to explain to a paramedic, like, because it's always the, you know, I was just doing this, and then it always goes into, you know, crazy town. But anyways, if you were to do a speculum exam for somebody's nose, you tip their head back a little bit so you can see better. And I've never dilated a nares. I just normally use the otoscope with the same cover that I used for their ears. And sometimes you can see, you know, discoloration, sometimes even like perforations in the septum, bleeding or crusting, and often you can see like that the turbinates are swollen and such as well. And so this is the dilator, which I think looks awful. Like, I feel like if we were really needing to do that, it would probably be at an ENT office. So examination of mouth and throat. I wanted to highlight something here. Oftentimes there's a lot of hype going around these days about, you know, bias in healthcare, racism in healthcare, or really everywhere, right? But if you think about just some of the things that we learn are all geared to white people, okay? And I'm not going to get into a political debate at all. I just wanted to highlight here that oftentimes when we're talking about cyanosis, okay, we say, look at their lips. Are their lips blue? Are their fingertips blue? But people of color, they won't turn blue, okay? And so that is this strictly, but it's kind of taught as this overarching, it has to be this kind of thing. And it's like, no, we need the disclaimer that, you know, people of color with darker skin tones may have different presentations, okay? Because their skin won't respond to the same way that we do. So just something to keep in mind, okay? That in your patients of color there's other options, like look back under their lip here as well to see if there's any discolorations there. Okay. And then note the condition of the teeth and gums. Are they attached? Do they look clean? Do they look like they're being well cared for? Inspect the tongue and buccal mucosa for color, lesions, and presence of white plaque. We'll talk again in a little bit about that white plaque. And then you do use the tongue depressor to depress the tongue to visualize the tonsils, uvula, and pharynx. Most of the time, I don't need to use the tongue depressor. I can just have somebody open their mouth really wide and say ah for a long time, and most of the time I can get a good enough view without gagging them. And then palpate for cervical lymph nodes for swelling. So when I do lymph nodes, I palpate here, behind the ear, and then down along the jaw here until you get to the chin, and then down. Okay, in a normal person, you shouldn't be able to feel anything. Otherwise, they'll feel kind of just like little balls underneath the skin. And when someone is sick, it's common for them to be tender, for those lymph nodes to be tender. It's concerning when you have a lymph node that's palpable, that's non-tender, and it's been there for a while, okay? That's a more worrisome sign. Hearing loss, like we talked about, it can be really pitch specific, okay? And for instance, like babies hear high pitches much better than low pitches. And I don't know if you've ever noticed, whenever you're around a baby, everybody's voice naturally gets higher and they start to talk in this like high pitched, squeaky Mickey Mouse type voice. Okay. And it's just something that somehow genetically we know to do. Okay. And then, but oftentimes, as patients get older and have harder and have a harder time hearing, they have a harder time with the higher pitched voices. And so oftentimes, if I have a patient who's truly hard of hearing, I'll even try to lower my voice. Okay. And so deafness is that inability to detect any sound, versus hearing loss can be both conductive or sensorineural. Conductive hearing loss is like when somebody's ears are full of wax. It can really decrease their ability to hear, versus also if um, if they have like a big URI or like allergic response and the eustachian tubes are blocked, that can also result in a decrease in hearing. And so those are kind of mechanical dysfunction, short-term things. Sensorineural loss involves the inner ear, the actual inner ear's ability to hear and understand. So otitis externa, more commonly known as like swimmer's ears, inflammation or infection of the external auditory canal and tympanic membrane. Okay, it can be from a lot of different things: bacterial, fungal, eczema. It can even be a chronic thing. Okay, and so it's really important, especially in those like swimmers, to make sure they're drying their outer ears well. Okay. Otitis media is the ear infection that we all know about. Okay. Presence of fluid in the middle ear accompanied by signs or symptoms of infection. And it gets the incidence dramatically decreases with age. And I want you to think about the anatomy. If you remember back to that slide that showed us the eustachian tubes, I could tell it was in an adult because the eustachian tubes had this kind of sharp angle like that. Okay. Versus for a child, it's more flat. Okay, so it's a lot easier for stuff to get like backed up here. And so if like a 5-year-old has congestion here, it's a lot easier for it to just back up that eustachian tube and cause that pressure and that fluid buildup behind the ear. It can be both viral or bacterial in nature. Okay, and can sometimes occur with that URI as well. Ruptured tympanic membrane is, that change in air pressure either caused by blunt trauma or infection. If that fluid builds up, just builds up, it can eventually pop. And people will often say, yeah, my ear hurt so bad, and then I heard this pop and I had this weird drainage, but it doesn't hurt anymore. And so they think that they're all better when really they ruptured their membrane because of the extent of infection or from the trauma itself. And so it's not to say that like a ruptured membrane is like will severely affect their ability to hear. It's not like, oh, I ruptured it once and now I'm done. There's just scarring. It will heal over, but there is scarring. Like I said, purulent fluid or bleeding can come out of the ear after that rupture. And it's important, like I said, don't put anything in there, like Q-tips, whatever. It's best just to leave them alone. Because sometimes even if you were to put like a Q-tip in there, sometimes you can actually rupture your membrane yourself. Allergic and non-allergic rhinitis. So allergic rhinitis is modulated by the immunoglobulin E, which is responsible for, like I said, allergic responses. And it creates this like cytokine storm where all these different histamines come. And essentially what they're trying to do is your body is trying to flush out the allergen, and so that's why your nose runs like crazy and such, and because it's trying to get rid of it. And so it's a little bit ironic that we use antihistamines to help treat your allergies, because you would think that if the histamine is trying to get rid of the allergy, if I just take so many antihistamines, isn't that just letting the allergies hang there longer? And that's 100% true. It is. And so it can become this like vicious cycle. So if you're not doing something to help control that allergic response in the first place, and decrease your exposure as well, you'll still struggle with that. So, and I think we had talked previously that most of the receptors for allergens, for seasonal or non-seasonal allergies, are in your nose, so it's best to control nasal symptoms with like a nasal steroid. Okay, and you can just get them over the counter. Flonase is a good one. Okay, and it takes about a week to start working. Non-allergic rhinitis is that nasal inflammation due to infection, vasomotor, occupational, hormonal, drug-induced, and others, and it produces excessive mucus. So essentially what it is like I got exposed to some type of weird fumes, and then I got inflamed from there. Okay, so allergic versus non-allergic. Sinusitis, anytime, remember, you see that itis, it's just inflammation of the sinuses. Can be acute, subacute, recurrent, or chronic, bacterial versus viral. And it's blockages of the passageways that connect the sinuses to the nasal cavity. So oftentimes people just get so much pressure either like in here or up in their head because the fluid that's building up in there isn't able to drain out. Okay, and like I said, bacterial versus viral, it's really hard. Like I don't give people antibiotics for a sinusitis until it's after day 10. Okay, if you've been with it 10 days, that's typically the length of time a viral would have run its course. And so after day 10 is a good indicator. And otherwise, if there's a time when people were like, I was super, super sick for days 3, 4, 5, 6, and 7, I felt so much better. And then 8, I was just done. I was super symptomatic. That's called a double sickening, meaning I was sick, I got better, and then I felt sick again. And so, and then that's another indication for antibiotic use. The deviated septum occurs from trauma, often a blow to the side of the nose. Epistaxis, which is just a fancy word for a nosebleed, is often associated with nasal fracture. And often, yeah, we find it on just like a routine nasal exam. Epistaxis, like I said, nosebleed typically occurs with trauma to nose, but it may occur without trauma. More than 90% occur anteriorly. The posterior bleeds is usually more profuse and has an arterial origin. And please stop people from plugging their nose and walking around like this. It's like, no, that's not a good idea. You want to pinch right at the bridge of the nose and lean slightly forward, and you can put some ice on the nose as well. Afrin is also a medicine that we use sometimes to stop nosebleeds. Pharyngitis and tonsillitis, sore throat, either inflammation of the tonsils or the pharynx. Oftentimes these are viral to start with, and sometimes bacterial infections follow up after them. This is like the strep throat that you think of. But I also want to remind you guys of mononucleosis. Okay, so we heard about it often in high school as like, the kissing disease, which is true. It's passed, from close contact, sharing toothbrushes, sharing drinks, those kinds of things. It's not just kissing. But so people with sore throats for a while, lots of fatigue, could actually have mono. And why we really care is that mononucleosis can result in liver and spleen enlargement. And if we miss it, it's super possible that you send your soccer player out onto the field that you think just has a sore throat, and they actually end up rupturing their spleen. So that's one to always kind of keep in the back of your head. Laryngitis, inflammation of the larynx, often occurs simultaneously with common cold, bronchitis, pneumonia, or influenza. When people just say they like lost their voice or their voice sounds different. It can also happen because of, direct trauma to the throat, GERD, so that constant acid reflux, allergies, cigarette smoke, or just talking a lot, using their voice a lot. I'd never heard this phrase before, but sometimes called cheerleaders nodules. So that was interesting. And I couldn't help it. She has nodes and essentially just pharyngitis. Pitch Perfect one, in case nobody gets the reference. Just saying. Oral mucosal lesions can be a result of local trauma, infectious, autoimmune, neoplastic, toxic. Um, it's so important for early identification because these could either be oral cancer or the first sign of HIV or AIDS. Okay. Um, and so if you're looking at somebody's mouth for a reason, you have to make sure you look at all the different areas, like inside the cheek, under the tongue, are places where they kind of like to hide too. Oral candidiasis, your a book said that it's yeast-like, and I was like, no, it's just yeast. It's Candida albicans, which is a type of yeast that can occur in the mouth, okay? And it forms this white, cheesy, curd-like patch on the tongue and buccal mucosa. And it's important to note that you can't scrape it off because sometimes people will come into me super concerned because they have this like white type of growth on their tongue. And it's actually like it's a sign of generally poor dental care, but it doesn't necessarily have to be. But it's easily removed, okay? So like if I take my tongue blade, I can just scrape it off, okay? Because it's just kind of like a buildup. Versus oral candidiasis, that stuff is stuck, okay? And it's common in newborns, but also people after taking antibiotics, okay, can develop oral candidiasis. And then also people who use steroid inhalers, okay. So when you use steroid inhalers for asthma or whatever, you have to rinse your mouth afterwards. Otherwise, you'll let candidiasis grow. Okay. And typically, it's treated with like an oral rinse or an oral antifungal. That can last a while. Oral cancers, like we said, in tongue, lips, and gums. About 3% of cancers in men and 2% in women. More common in African Americans than Caucasians. Tobacco use, excessive alcohol use, poor oral hygiene, age greater than 40, and family history of oral cancer are kind of predisposing factors. And then dental disease, gingivitis is inflammation of the gums caused by bacteria. And the bacteria comes from the food that we don't get off good enough when we brush or floss. And then the bacteria also have a food source in order to let themselves continue to grow. And periodontitis is what happens if gingivitis is left untreated. And essentially what can happen is the gum line can recede off of the bone, and it can make you more susceptible for tooth loss. And we're talking, and it's also important to keep in mind that, like, dental health is super important. Poor dental hygiene can actually lead to like endocarditis, which is, inflammation of your heart. And so there's a lot more tied into it than just your teeth, because sometimes people think, oh yeah, who cares? It's really not that big of a deal. But it really is. Dental health, the more we learn about it, the more we know that it's kind of involved in a lot of different things. And so dental caries, the cavities that we all hear about, tooth decay caused by accumulation of that bacteria on the enamel surface, and it goes from enamel to dentin to pulp of tooth is how it progresses. Okay. So that's it for this one. Once again, reach out to me if you have any questions or concerns. Big things to keep in mind, like we had talked about, one of the big ones that sticks in my head is the mononucleosis with your patients with sore throats. It's a fast, easy monospot test to test for, because the risk is fairly high, because if we miss that one. otherwise, most of these conditions are pretty benign, pretty self-limiting. But then there's also an awful lot of symptoms that overlie with COVID too. So that's the big struggle that we're in these days, is how do I know if my runny nose and my cough is, just a normal runny nose, or is it COVID? And so that's an entirely different discussion. And part of why there's so many protocols on like testing frequencies and such as well. So alrighty guys, let me know if you have any questions, and I'll talk with you next week.